Of course. Thank you very much, Jean-Michel. It's a pleasure for me to discuss the evidence related to some of the recommendations from these guidelines. We have no time to discuss all the 19 recommendations of the guidelines, so we will select and focus on one of the clinical questions. Let's first discuss the patient's population and the definition that we use to search the literature. First, we refer to patients, hypoxemic patients that require non-invasive respiratory support with any of the techniques that Audrey and Professor Chabert described before. It is important to focus that we searched paper on perioperative and periprocedural period for curative use, as we may recall from the presentation of Professor Chabert. With this definition of hypoxemia, we cannot find a reliable definition of hypoxemia, maybe a lot of definition around, so we selected by consensus this to select the papers. We selected trials that used all these interventions, high-flow, CPAP, and NIPPV, versus or conventional oxygen or any head-to-head comparison between these interventions. And obviously we focus our attention on randomized control trials because in this way we can apply the grade approach to the evidence and performing the assessment of the certainty and the quality of the recommendation that we proposed. So we focus now on clinical question number 2. We have 5 clinical questions in the guidelines because in my opinion this clinical question is the most patients related and maybe something that can resemble all the literature that we selected for this. And these clinical questions was about which patient population may benefit for the use of non-invasive respiratory support technique in hypoxemic patient with acute respiratory failure perioperatively or periprocedurally. And the panel selected, because found some literature, on 5 clinical settings. The first is post-abdominal surgery, post-cardiac surgery, post-lung resection, post-transplant, and during fiber optic bronchoscopy. So the first is about post-abdominal surgery, and this is one of the 2 recommendations about this. And we have a strong recommendation with moderate quality evidence, so 1B, suggesting use of non-invasive positive pressure ventilation or CPAP immediately post-extubation for hypoxemic patients at risk of developing acute respiratory failure after abdominal surgery. And we should focus that 1B is the best level of evidence that we apply to only 2 recommendations in the guidelines. And in this topic, we selected 2 trials, one from Vincenzo Squadrone and colleagues, and one from Professor Chabert and colleagues, both published in JAMA, and one comparing CPAP to conventional oxygen therapy, and the other one NIPPV versus COAT. It is important to underline that the trials enrolling patients with different severity of disease, Squadrone only patients with hypoxemia, and Professor Chabert and colleagues, patients with hypoxemia and signs of respiratory failure. And based on these 2 multi-center trials with low risk of bias, we applied this high grade of recommendation, strong recommendation and moderate quality evidence. In this case, we found also a trial comparing high-flow nasal cannula versus COAT, but the panel decided not to include any recommendation for this because patients included in this trial was at risk of developing hypoxemia or postoperative pulmonary complication and not hypoxemic at baseline. So for this, the panel decided not to create a statement on this evidence. About post-cardiac surgery, weak recommendation and moderate quality evidence suggesting either non-invasive positive pressure ventilation or CPAP that can be considered for prevention of further respiratory deterioration in hypoxemic patients after cardiac surgery. And the studies supporting this recommendation were 2 single-center randomized studies with some limitation. The first is related to the sample size, because both of the trials enrolling almost 70 patients. The first from the Brazilian group, comparing 2 types of NIPPV versus CPAP, and the other one from Italian group, comparing CPAP versus COAT. It is important to note that this last trial enrolled patients in the world, cardiac surgery world, not an ICU. So CPAP versus COAT in cardiac surgery. And there is also a weak recommendation with low quality evidence suggesting the potential use of high flow that can be considered for hypoxemic patient after cardiac surgery. And this recommendation, weak recommendation, was based on a multi-center French study, the BIPOP study, that compared high flow versus NIPPV. This was a non-inferiority study that showed that the efficacy of both interventions in terms of treatment failures was within the non-inferiority margin. And for this reason, the panel decided to create a statement. Also because there was a higher rate of skin breakdown in the NIPPV group, that lead the panel decided to create a recommendation suggesting the use of high flow even with weak recommendation. What about post-lung resection? Again, weak recommendation and low quality evidence suggesting the use of two levels of pressure that can be considered for prevention of atelectasis in hypoxemic patients after lung resection. Again, we have here a single-center randomized trial published in the Blue Journal comparing NIPPV versus COAT. This trial was a single-center trial, prematurely stopped for efficacy on NIPPV. And this is the reason why the panel decided to assign a weak recommendation. And about the post-transplant, again, a weak recommendation with low quality evidence for a trial, a single-center trial, comparing again NIPPV versus COAT for around 40 patients included, and that was dated again in 2000. So for this reason, the panel decided to grade down the evidence, not only based on the sample size or the type of study, but because in the last 20 years, the field of transplant has completely changed. So maybe we need more data to clarify the use of this support in this setting. And the last one is about fibropathic bronchoscopy, weak recommendation, moderate quality evidence based again on two single-center studies, CPAP versus COAT1 and high flow versus NIPPV. Both in one suggesting the efficacy of CPAP versus COAT, and the other no clear difference about high flow and NIPPV. So in hypoxemic patients requiring bronchoscopy, there is a suggestion for general intended non-invasive respiratory support techniques rather than COAT. So as conclusion, just few head-to-head comparison. Most of the trial compared an intervention versus COAT, and there is generally a low quality evidence apart from the setting of post-abdominal surgery where we have two multi-center trial, well-performed trial.
Thank you, Andrea, for this presentation. And I think it's nice to clarify the different studies that have been included in the guidelines. I have just a question from one of our colleagues from Malia, who asked, and I think it's important for non-experts in the literature, what are the differences in terms of outcomes between prophylactic and curative care for postoperative hypoxemia? One of you, Audrey, maybe? Not?
Yes, the literature was treated by Andrea. So
the difference in the outcome we need to focus on in curative and prophylactic care of the patients.
I think that the outcomes are quite similar, and maybe the outcomes. Because most of the studies focusing on oxygenation, rate of intubation, it's very difficult to set up a study addressing perioperative mortality, only focusing on the non-invasive support for oxygenation or ventilation. But another point could be the rate of postoperative pulmonary complications, because this is an outcome that is clearly defined. There is a clearly statement for what we should search for when we select an outcome like this. So I think that for prophylactic study, oxygenation and reintubation are the most common and maybe the most suitable. and the rate of complications may be something that can be addressed better for curative. And I don't think that there is not so much space for mortality for the study that we discussed before.
I fully agree with you. Just one other question before to move on. What could be the difference between complication after cardiac surgery or abdominal surgery? Is there any rationale to say it's different, or it's just the inclusion criteria?
I think that is rational to think that the underlying patients are different, because if a patient is undergoing cardiac surgery, there is a reason. And maybe the rate of comorbidity, cardiac comorbidity, is higher than abdominal surgery. So I can think that what patient can face after the surgery is different. But for example, in abdominal surgery, maybe the rate of comorbidities can be lower, focusing on cardiac surgery, but the mechanic problem related to the wounds, to the access to the abdominal cavity, can create difficult for the patient, some issues for the patients for the ventilation. So the patients may be different, but both has to face some important problems afterwards, for example, for oxygenation, both, and ventilation.
Okay. And Audrey, on a theoretical point of view, is there any difference in the device you are going to choose in post-cardiac surgery or post-abdominal surgery?
And the literature has some answers to provide also in cardiac surgery, after cardiac surgery, where recent studies in preventive ways found no difference between high flow nasal oxygen and non-invasive ventilation. So maybe in this specific topic there is no difference. After abdominal surgery, in a theoretical point of view, non-invasive ventilation could be useful because a lot of atelectasia are promoted by abdominal surgery, and the PEEP support is higher than the one provided by only high flow nasal cannula oxygen. So maybe it could be the method of choice to prevent respiratory failure after abdominal surgery.
Okay, thank you, Audrey.